Lori Styner, as I said earlier, is the Director of Research at the Prostate Cancer Centre. She holds a Bachelor of Nursing degree and has over 30 years experience working in clinical research in academic, community, and industry settings. I had the privilege of meeting Lori when I first started working with the Man Band 2 years ago, and I now have the privilege of working with Lori and her team doing some volunteer data input in the research area. So these are great people. She's got a wonderful team in there. And Lori's going to provide us with an overview of the types of research and current activities conducted at the Prostate Cancer Centre. So without any more jibber jabber, welcome Lori. Thank you so much for joining us.
Thank you, Kelly, for inviting me to present tonight. I'm so pleased to be able to share my passion for doing clinical research in Calgary. I've been involved, as Brad mentioned, in research for over 30 years and probably worked in just about every therapeutic area you could possibly imagine: cardiovascular, respiratory, infectious disease, neurology, smoking cessation. The last 4 years, however, has been prostate cancer, and I really think that the way we've been able to make our program grow at the Prostate Cancer Centre, that we're truly making a difference. The prostate cancer research at PCC, the Prostate Cancer Centre, is an important component of that centre. And not only do we do basic science, looking at better understanding of diagnosis and treatment of prostate cancer, we're also doing clinical research to test new treatments and diagnostic modalities to reduce mortality and morbidity, so illness and death, in patients living with prostate cancer. Our facility is very unique, and we've gained recognition not only in Canada as being a top research facility, but worldwide as well. And I'll tell you why in a little while here. Our facility is quite unique, and if I could have dreamed 30 years ago where my career would end up, and the facility and the support groups around, I couldn't have picked a more perfect environment. And the reason is that we have a facility where I call it one-stop shop. So patients coming into our clinical trials, we're not sending them to the lab for an ECG. We're not sending them to the lab for blood work. As we've grown, we've gained new equipment and expertise in areas so that we can do everything right on site. And the only thing that we're not able to do is imaging, CT scans, bone scans, etc. So our site is very appealing from that aspect, but even more importantly, with the urologist just across the hallway from us, the support we have from a medical standpoint is absolutely amazing. And this is one of the things that we attract research to our center, because we need to be able to show that we have good physician oversight over everything we do. So this has been a real plus for us. As well, with our research, we look at the research patient as a whole. So I do a lot of the triaging for the clinical trials, and there have been many a times where I've said to the urologist, I don't think we should put this patient in the trial because it's going to delay their treatment, whereas they could start treatment now, and that's best for the patient. And so it's very comforting to work in an environment where there's no pressure to enroll X number of research patients in a study. So I'm able to look at the patient and really help the urologist decide what's best for that patient, and that makes us, again, very successful. All righty. So just reviewing the agenda, I will show you a picture of our team, talk a little bit about the research conducted at PCC on a very high level. It would take all evening to go through all of our research programs. Current studies, be talking a little bit about two key studies, the Iqari Study and the Spartan Study. I'll share with you some of our key accomplishments from 2017, And then I'm going to talk a little bit about clinical trials of phases of research, because you probably hear about phase 1 or phase 2 or phase 3 research. So I'll go into that. And then I think it's important to talk about the regulations, the rules that we follow, because it is not easy doing research. There are so many rules, and we have to follow them. Otherwise, we wouldn't pass any ethical board approvals. And then lastly, I'll talk a little bit about conducting a clinical trial, some of the activities that take place. Okay? So this is our team. 4 years ago when I started at the PCC, there was myself and an assistant, and we were seeing or conducting about 7 patient study visits a month. And now, 4 years later, with this great team, we're conducting over 135 patient study visits a month. So the growth has been absolutely tremendous. And this team consists of foreign physicians, registered nurses, phlebotomists. We've got people with science degrees, all kinds of backgrounds. Every single one of our staff members was completely green for research. They had no research experience when we hired them. And I did that on purpose. And the reason was that having so many years experience, I wanted to train them to do it the right way. And so this has been hugely successful, and the career growth, I mean, my research assistant or administrative assistant that I hired 4 years ago, she's just now left us to move further east, but she ended up being promoted to a research coordinator with an administrative background because she was just that good. So we really, really have a fabulous team. So these are our permanent staff at the Prostate Cancer Centre, but then we work very closely with the urologists. Dr. Brian Donnelly, Dr. Jeff Gatto, Dr. Dushinsky, Dr. Carlson, Dr. Heinemann, Dr. Lee. At any given time, one of those urologists will be heading up one of our research studies, and we are in constant contact, and weekends, evenings, because one of the things about research is a patient in a research study where there's intervention being done and that they're on a new treatment have to have access to a study team member 24 hours a day, 7 days a week, and that's me. But what the great thing about our group is that I have the support of the urologist, so it's not surprising for Dr. Gatto and I to be texting back and forth about a patient on a weekend if there's a need to discuss a different intervention. Okay. Just to show you what our research unit looks like, we have quite a nice modern lab, and that came into play about 4 years ago at the time I was starting. So our team houses this great big space at the Prostate Cancer Centre. In this lab, we do all our blood processing and prepare it for shipping. The coordinators on the studies all have their work area. We have a huge storage room. The amount of supplies we need for studies is enormous. We also store all of our study drug in this unit. So it's great we have this space. And we have pretty much outgrown it now, so not sure what we do if we keep getting bigger, because we'll have 2 people sharing a desk soon. Okay, so talking a little bit about the types of research at our center, we do both bench research, so if you think about specimens being analyzed under a microscope, that would be bench research, where we're looking at the Iqari study, which I'll talk about in more detail, looking at what biomarkers, what are the genes, the proteins, etc., in the specimens that we collect that are indicative of an aggressive prostate cancer. So one day this bench research that we're doing will lead to what we call bedside care, in that it'll make a difference in the type of care a patient might get. The other type of research that we're doing are the clinical trials, and these are studies involving human beings, okay? There's 2 different types that we do. Interventional, where we're comparing treatments within a patient population. Now, we do primarily prostate cancer research, but we also do research in other urological diseases. So if any of the urologists want to do a research study, they'll come to me with a proposal and I'll evaluate it and see whether it's something that we might want to do. But primarily we do the prostate cancer. Okay? And with our interventional research, we're looking at how well does a drug or a diagnostic tool work, and how safe is it? And so we would always comparing 2 or more treatments. We also do non-interventional research, which also could be called observational studies. So in this case, we may have patients taking a particular drug that's marketed, but what we're looking at is collecting data to see what are the outcomes and what are happening to these people in the real world and not in such a controlled setting of an interventional clinical trial. Okay, so this is a really busy slide and I'm just going to give you a very high-level overview of what we're doing now. So currently we have 3 studies that we're recruiting patients for. Iqari Study, I'm going to talk in more detail, so I won't talk about that right now. The HERO study is a study looking at the safety and efficacy, how well does this investigational drug work for men with advanced prostate cancer. So I think a lot of you are probably familiar with the hormone injection Eligard, and by the way, Brad, I give really good injections. Here next time. This is pill form doing the same thing. So it's something we're looking at. Patients are enrolled. There's all kinds of criteria they have to meet. And they're taking a pill, well, it could be a couple of pills daily, instead of the injection. The neat thing about this particular drug is that unlike Eligard, where you get initially a flare, testosterone rise, this particular drug has an immediate decrease in testosterone levels. So that's kind of neat, because if any of you have been on Eligard and had to take Casodex initially, you don't have to with this drug. Okay. Then the Gert Study, this is one of our observational studies, and this is kind of neat as well, in that it's a study going across Canada with this Genitourinary Research Consortium, and what they're looking at is the patterns of care, disease progression, and outcomes in patients with advanced prostate cancer. So we're collecting data such as when was this patient diagnosed, how many PSAs did they have, what were the PSAs doing, how many scans did they have, what treatment did they get, and so forth. And they're going to compare this data, which will be really interesting to see, do we have better outcomes when different patterns of care were taken on. Okay. Ongoing studies, Embarq is a study for patients that have had radical prostatectomy or radiotherapy, so they've had what we would hope would be a curative treatment, but their PSA started rising, okay? And so in this group, we're comparing what the standard of care would be, which would be the hormone injection. We're comparing that with hormone injection plus a pill enzalutamide, or the enzalutamide alone. And this is a really great study. The population in this group tend to be more of the younger men that surprisingly their PSA started rising. Aramis is a study with a new investigational agent, and it's looking at men who have been on hormone treatment, but their PSAs are rising, and we call that castrate resistant. And currently, there is no marketed drug in Canada for that phase. And I'm not sure how many of you are familiar. So that study and Spartan, which I'm going to talk about more in detail, are very near and dear to my heart, because we don't have a marketed treatment right now in Canada to give patients when they're at that stage of their disease. So these studies have offered patients, at least the patients we've had exposure to, a treatment that may help the progression of their disease. Cosmic was another observational study looking at Zytiga, abiraterone, again looking at what happens in real life when patients are on these particular treatments. Titan is using the same drug as Spartan, apalutamide, and it's looking at patients who are newly diagnosed, but diagnosed with metastatic disease as their first diagnosis, and we're trying them on an investigational treatment along with their hormone injections. Spartan I'll talk about in more detail, and the Enzyme study is comparing enzalutamide with Casodex in patients with metastatic prostate cancer. So one of the things I'll mention about our studies that when we take on a study, we have to tell the sponsor, the funder of of the project, how many patients do we think we can enroll. And that's always discussion with the urologist based on their patient population. And we've had incredible success. So almost all of our studies were a top recruiting site in Canada. And it's partially because of the great rapport we have with the urologist, but also we're very linked with the Tom Baker Cancer Centre, and they want their patients in clinical trials to get a bit closer observation and care. And so we get a lot of referrals. But not only do we have the great recruitment, we have the quality of work to go with it. So every single study, we get audited about every 6 weeks, and we're squeaky clean. So it's really nice to have the success in the studies, but also know that the quality of work is really second to none. Okay. So in 2017, our key accomplishments, so recruitment and retention. So I've talked a little bit about recruitment. One of our studies, we were looking at a new diagnostic tool. It was a dye, actually, during a CT scan to help better identify aggressive prostate cancer. And our goal was 20 patients, and we recruited 79 patients, which was we were the top site in North America. And again, we had an audit, and I think the worst thing they could find was a spelling mistake in our data entry. So we're pretty proud of that. The other thing that we're really proud about is our retention in clinical trials. So when we're assessed to take on a new study, an evaluation process takes place where the potential sponsor comes to our site. They always ask us, how are you going to retain your patients in the study? Because prostate cancer, the studies are all really long term. And we have over a 98% success rate in retaining patients into study. And I like to think that's because we make the experience a pleasant experience coming to the site. We really care about our patients, and we are available 24/7 for them. So we've had really good success. One of our studies, the Spartan Study, which I know that Kelly had in the newsletter, the groundbreaking results about the drug apalutamide. I'm going to talk about that when I talk about the Spartan Study. Again, I've been doing research so long, but really there's not that many times where you sit in a meeting room and hear a result as outstanding as this particular one. So it's pretty satisfying to hear that. In 2016, we conducted about 1,200 patient visits. In 2017, we're at 1,600 study patient visits. That's a lot of patients that we see for research. And in 2017, we were following over 100 patients who were receiving investigational treatment. And again, going back to 2014, when I started at PCC, we were following about 7 patients. So we've really grown. And the Iqari Study, again, I'll go in more detail. They're bringing in another 500 new patients yearly in that particular study. So I'll talk about that study now. So the Iqari Study Iqari stands for the Alberta Prostate Cancer Registry and Biorepository. And later on, when these results come out, probably, it's going to be a few years down the road, you'll remember this name because this is going to be exciting. So what this, it's a cohort study. We're not intervening, we're not changing anybody's medication, we're simply observing the patient's health outcomes and collecting lab samples on them, blood and urine specimens. And what this would be our bench research study. we're looking at identifying new ways of detecting and predicting serious prostate cancer. So with the blood and urine specimens that are collected, the researchers are looking for biomarkers that will better identify serious cancer, because as we all know, not all prostate cancer is going to kill you, but the more serious ones will. So I look at this study, one day my son will have a blood or urine test, and in that test it's going to tell him is whether he'll ever develop prostate cancer, and if he's going to develop it, is it a serious one that needs to be treated. So this is really, really exciting. Okay? And the methods, we're collecting biological samples and health information. Patients sign up for the study, we collect the samples, and we see them on a yearly basis to collect those samples. Okay? And if any of you are interested in being part of that, speak to me after the meeting. I don't push anybody into any study, but if that's something that you'd like to contribute to, I can give you some information on that. Okay. The Spartan Study. This is a really busy slide, so I'm going to really simplify it. So the Spartan Study on patients who had already had what I'll call definitive therapy, and that they've had a prostatectomy, they've had radiation therapy, and they've received hormone therapy. But despite that, their PSAs are rising. They're rising at a velocity that they're at risk for developing metastatic disease, and they don't have metastatic disease. The sad thing is, right now, as I mentioned, we do not have in Canada on the market a drug for that particular stage of prostate cancer. So what the urologists have to do, or what they can't do, is that they have to wait until that patient develops metastases before they can prescribe a treatment. So this study was looking at an investigational drug, apalutamide, and the apalutamide, I call it the goalie. So you've got your hormone injections that are preventing the body from producing the male hormone testosterone. Apalutamide is blocking any other testosterone that might have been produced by the adrenal glands from entering the system, okay? So it's kind of like a double blockade of preventing the body from taking up testosterone, because testosterone is going to grow those cancer cells. So patients were randomized either to the apalutamide plus their hormone injection, or a placebo and the hormone injection. 2-to-1 ratio. So for every 2 patients were getting the apalutamide, 1 patient was placebo. Now, is this ethical? Of course it is, because if they weren't in the study, all they'd be receiving is the hormone injection. So the worst case scenario is they're receiving what they'd receive if they weren't in the study. Partway through, they did an interim analysis, and we were told that there was benefit to being on the apalutamide. So what they did was they unblinded the study, which means that they told the patients what they were receiving, either the placebo or the apalutamide, and those that were receiving the placebo had the opportunity to receive the study drug. So in the case of in Calgary, we had 6 patients on the study. 4 of them were receiving the apalutamide, 2 were not. 1 had already progressed in his disease, but the other one, his PSA was, trying to think what it maybe had risen to, maybe 14 or so. He got on the apalutamide. I saw him in the last week, and his PSA is 0.1 now. So it's just absolutely phenomenal, the reduction in the PSA that this drug is showing. So key results of this study. Apalutamide decreased the risk of metastases or death by 72%, and prolonged the median metastatic-free survival, so the prevention of the disease progressing, for more than 2 years in that population. So the results are just absolutely outstanding. And the other thing that's important, in just about every study we do for prostate cancer, we do quality of life questionnaires, because it's one thing if the drug is treating the cancer, but your quality of life has now diminished. That's not a good thing. And what it showed was that the overall quality of life was still really quite positive. It was maintained while on the study drug, so that's a really good thing. Now, the study drug apalutamide, because of the success, was fast-tracked and approved in the US by the FDA. And it's now marketed in the US, so it's available in the US. And Friday, I received an email with some really great news that it's now been approved by Health Canada. And in all my years, I've never seen a drug approval that quickly. So obviously the regulatory authorities are taking this quite seriously, that this is a good thing, and have approved it quickly. The marketed name, I think, is called Erleada. Let's see. ERLEADA is what it's going to be marketed as. We don't know when the pharmaceutical company will market in Canada, because there's some hurdles to overcome with pricing and all that type of thing. But it's really good news. And I'm not sure if you recall, we had another study, the Titan study, that was also using apalutamide in patients that already have metastatic disease. I don't know any results yet of that study. However, I do know that the company is preparing to again unblind that study and allow patients that did not get that drug. So I'm expecting some positive results to come out of that as well. Okay. Any questions about any of the studies? Mm-hmm.
What are the side effects for apalutamide?
So they're similar to what they would be from the hormone injections. So the most common things that I see are hot flashes and fatigue, and those can be fairly common. And again, all these people that are receiving the apalutamide are also receiving the hormone injection, so it's hard to say. When patients are in a research study, when they come in for their visits, we ask them the question, have you had any health changes since the last time we saw you? And so we track everything from the common cold to the little skin rash to everything. So it's the urologist's job to make a decision on whether they think the drug is related to that particular health condition. So, but would say the hot flashes and the fatigue are the most common things. And I often ask the patients, when they complain of what they think are side effects from the drug, I'll ask them, is it worth it to have those side effects, and knowing that there's a good likelihood this is preventing the progression of your disease? And 100% of patients say absolutely. So everybody lives with them. Yeah. So talking about the phases of clinical trials, and this slide is an oncology example. So preclinical, we have our lab studies. So that would be, well, I'll just say under the microscope. Not on this slide, we also have what's called phase 0, which I'll talk about, phase 1, phase 2, phase 3, phase 4. And phase 4 generally are post-marketing studies, our observational studies. Okay. So the clinical trials are all done through the phases, and each phase is designed to answer a specific question. And the next phase of research can only start once the previous phase has been shown to be safe and effective. And I've mentioned there's several phases involved in a clinical trial. So the preclinical, they're looking at wide doses of drugs, and that may be tested in test tubes or cell cultures or in animals. Phase 0 would be using a very small dose of drug and seeing how it works in a group of people. And this is not necessarily determining whether it's effective against cancer. It would be more looking at pharmacological data and seeing how is the body excreting it and what levels are in the blood after so many hours and that type of thing. And this is the beginning stages of, well, again, moving on to the phase 1. I'll just move on to that. So phase 1, so I'll just mention that we do not do, as far as drug trials, we do not do preclinical, we do not do phase 0, we do not do phase 1. The reason is we do not have the facility for that. So a phase 1 trial would essentially be having patients having to stay overnight. We'd have to have a doctor there 24/7 and that type of thing. We don't have the facilities for that. So the phase 1 would be looking at how a treatment should be given, how often, and what is the safest dose, and looking at what effects the drug or therapy has on the body, and looking at side effects. And we'd only be looking at a small group of people, about 10 to 15, okay? Phase 2 is learning more about how effective a treatment is for a certain type of cancer, and we'll look at how safe the drug is and what effect it has on the body. This we're starting to get into a bigger population, and but it's still usually less than 100. We may do the odd phase 2 research, but mostly we do phase 3. Okay? So phase 3 research is looking at whether the treatment being tested is better, as good, or worse than standard treatment out there. So when I talked about the Spartan treatment, or Spartan study, we were comparing it to the standard treatment, which was just the hormone therapy, and those studies show that it was much better than what the standard therapy was. Okay? We're also looking at the side effects, comparing new treatments and standard treatments. In the Spartan study, when we looked at the placebo group and the apalutamide group, the side effects amongst the two groups were really quite similar. There was no statistical significance in the differences. And in the phase 3 study, we're looking at large number of people. So the studies we do usually are worldwide studies, and we're just one participating site in Canada, so they're usually all over the world. So after a clinical trial goes through the phases and shows that a drug or treatment is safe and effective, it's submitted to Health Canada for approval. And usually that can take quite a long time to get that approval, but again, in the case of apalutamide, it was really quite quickly. And just to give a sense of time, it usually takes more than 10 years for a new drug or treatment to go from preclinical to the approval process. So it's a really, really long process. Okay?
How long did apalutamide take?
I don't know.
It was fast track,
So if I think, how long it was fast track? I'm thinking just a couple months. Yeah, which was pretty quick. And the study started in Calgary in the spring of 2015. So, okay. And those patients, I'm hoping that we bridge them, giving them the free drug until that drug is available, because they're all doing so well on it. So fingers crossed. Phase 4 research is our observational studies or our post-marketing studies. And they're looking at further evaluating the drug after it's been approved. So we still collect information on side effects, and they're looking at the different risks, the benefits when it's in an uncontrolled setting. And really that's very important, because when patients are in clinical trials, we count their pills when they come back, so we know if they've missed doses. When a patient is not under that tight of observation, we don't know whether they're taking their pills all the time. So it's important to have data to see what really happens in real life. All right? So now I'm going to finish with conducting a clinical trial. What's exactly involved? So the first aspect of clinical trial is site selection. And we're really fortunate that I have pretty much 100% confidence level that if a sponsor approaches us about the trial and we want to do it because we think we have the patient population, that we'll get selected. And the reason is that, again, I talked about our unique setup, that we've got the proven track record, we've got the facilities, and we've got the investigator, the physician involvement to do a good job, and that's all really, really important. So we're fortunate that usually we're in a situation we have to turn down trials because we just don't have the manpower to take on anything more. Okay. So once we've been selected, we need to get our site, what we call initiated. So one of the biggest jobs is the ethics submission. In Alberta, we have to submit to the Health Ethics Research Board of Alberta, which is probably one of the best ethics boards in Canada. A lot of the other provinces can submit to what we call a central ethics board, which could be in the United States, and it's like a rubber stamping. But in Alberta, we have to submit to our local board. From the time I submit a protocol to the ethics board, it's probably a good 2 months before I receive the approval, and there's a lot of back and forth with questions, and it's a really time-consuming process. Budget negotiation. So one of, again, a challenging task is if we take on a trial, I need to make sure that I can cover the salaries of our staff, and that is certainly challenging. However, saying that, we to date haven't discriminated on a trial that would be good for patients if the budget wasn't going to cover the cost. So we have one right now that we're losing our shirt on, but Dr. Donnelly said, you know, I want to do this study. It's good for my patients. I want my patients to have that drug. So we have to balance that out. But the pressure's on me for budget negotiation. My goal is to be $1 ahead of my staff costs. So we're not looking at profit for our research. We just want to do what's good for our patients. And the other thing about getting a site up and going, initiating a site, is the paperwork. It's absolutely mind-boggling. And here's just an example of some of the mounds of paper we're keeping for our clinical trials with what we call regulatory documents. Every piece of correspondence, it's just never-ending, the amount of paperwork with research. Okay, so I'm going to talk a little bit about some rules, because research has endless number of rules. And anybody involved in research, if I'm interviewing somebody for a new research position, I'm hoping that they've done a little bit of homework to know what GCP is, good clinical practice. And if they haven't, they're probably not going to get a job with us, because it's just the key word. And what it is an international quality standard for conducting clinical trials. It's many, many rules. But if we follow GCP, and Japan follows GCP, we can use studies from other countries, the data that's been used there, because we know they've been, the studies have been run to a certain quality standard, so we can use that data. But most importantly, GCP covers the rights, integrity, and confidentiality of trial subjects, and that's really important. Some examples would be that in order to do a clinical trial, there has to be a study protocol that meets certain criteria. Patients have to sign an informed consent, and there has to be a process for doing that. So the study protocols have to outline the why, what, and how of a study, and how the procedures need to be conducted. And we have to follow these protocols so closely that if I'm seeing a patient and I do their blood pressure and I do their heart rate and so forth, but I forgot to do their temperature, I probably have to write a deviation report because I deviated from the protocol. So we have to follow the protocol so precisely. And as well, we have to have our own site SOPs, which are our standard operating procedures. So that would be as far as if I'm speaking to somebody about a study, how do I do the informed consent process? We have a detailed procedure at the site level, and we probably have about 30 different SOPs that we follow. Okay, so conducting the study, the pre-screen phase, where we're looking at patient recruitment, before we would even take on a study, we would have a good idea of how we're going to identify our patient population. And for most of our prostate cancer studies, that is through urologist referrals. So sometimes I get calls from a patient with prostate cancer and said, do you have a trial for me? And I say, well, the first thing you need to do is speak to your urologist, because if they feel you need to change your treatment, then maybe we've got something for you. But if your treatment, what you're on right now, is working well for you, we don't want to change that. Okay? Referrals, I talked about previously from Tom Baker Cancer Clinic, and we weekly get referrals for patients to go into our studies. So the first patient contact is usually a discussion by the physician, and we also, patients that are coming into the Prostate Cancer Centre, we have them review and sign whether or not they'd like their medical record reviewed for purposes of research. So if they say yes, and we are approached by a physician about a study, then we can review their medical records. Often what happens, because again, the close proximity of the urologist, the physicians may see a patient that they'll speak to about a study, and then we'll get a call, can we come over and meet the patient? At that time, we'll give a brief overview of the study. It's usually overwhelming for the patient, because sometimes they've just been told they have metastatic prostate cancer and they're not going to retain any information. And we send them home with the consent form to review. So we would never want a patient to say, sure, I'll sign here, sign me up. Take it home, have your physician review it, your GP, have family members review it. Call me as many times as you need, but let's make sure this is something you really want to do. And then if the patient is interested in this study, we would book what we call the screen visit. So then we have them come in. We do, for prostate cancer, we're doing imaging scans, a CT, a bone scan. We're doing blood work. We're doing an ECG. We're doing their vitals. We're taking medical history. We're doing a physical exam. So we're doing all those kinds of things. Okay. So if the patient qualifies for the study, we would then do the enrollment visit. And so we get all the blood work back. We get the scans back. We put it into a report, we send it off to the sponsor, they approve it, and then we enroll the patient in the study. Most of our studies are randomized trials, which means that we have no control over what treatment the patient may get. We put the information into a website database, and it spits out to us what treatment that patient's going to receive. Okay? And then we usually have, especially for prostate cancer studies, a long-term treatment phase that could be several years. And as well, long-term follow-up. So if patients progress in their disease, they come off the study, but they stay in a long-term follow-up, which is by phone call. Okay. We have, one of our staff members is full-time in the lab, because the blood taking, the processing, the packaging, we need to send it, ship on dry ice, all that part. It's a huge, huge process. And initially, again, 4 years ago, my assistant was doing all of that, but now we have a full-time lab person because we're just that busy. In one of our studies, we have patients, we see them and they come back 4 days later for more blood work, and a week later, and that's just early on, but the lab part is really quite extensive. The study drug, so we have refrigerated drug, we have drug that's stored at room temperature. We have to take our temperatures of our various environments every day, because drug has to be stored at particular temperatures. If it goes out of range, we have to quarantine the drug, meaning we have to put it aside, we can't use it, we have to get a file reported. So we have a lot of study drug. Our room temperature cabinet is completely filled with drug, and our fridge is where we keep our Eligard, our leuprolide injections. So we dispense and administer all that drug, and the patients bring back their empty bottles or unused medication back to us. questions?
Are your studies limited to various drugs?
Sorry?
Are your studies limited to various drugs that you have to experiment with?
Oh, limited to various drugs, is that what you're saying?
Yeah.
Yes, so right now apalutamide is one. Enzalutamide is a drug that is on the market, but it's only available for right now metastatic prostate cancer. So one of our studies, it's a really, really good drug. One of our studies, we're bringing it in early in patients without metastases and see if that will help prevent metastases. And then you've got the Reluglex is one of the drugs. So we have a limited number of drugs that we use, but it just depends on the research trials. So if there's something new out there that might be benefit to the patients, Dr. Donnelly and I usually review the studies and decide whether this would be something good for our patients. So we would take it on if we thought so.
I'm part of the Warriors group, and we've had warriors that have participated in the Phase 3 trials for Aramis
Okay,
and for Prescreen.
okay,
Now, in those days, Calvin's participation in those trials happened through the Tom Baker Center. And one of the things that surprised me in the last few months, one at our symposium, when Dr. Gatto spoke, and also now with your presentation, you've made consistently references to the neurologist.
yeah.
And I'm wondering where the medical oncologist is, because in these two earlier drugs that are now mainstay, and apalutamide is simply an example of that, the medical oncologists are the individuals that have participated in the trials, developed the learning associated with the trials, and then are approved. And it's an exclusive list of who can prescribe those particular drugs. And urologists are not on that list right now today.
So we have two urologists that can prescribe those drugs. Dr. Gatto and Dr. Donnelly can both prescribe abiraterone and enzalutamide.
Through to the metastatic condition? Okay.
But they're the only two. And they would send their prescriptions over to the Tom Baker. So we work really closely with the oncologist, whether it's the radiation oncologist or the medical oncologist. And we're really careful that if there is a clinical trial that's better suited for the Tom Baker and we're approached for it, we'd get in touch with them and say, do you guys, maybe it's better if you guys do this trial, and they do the same with us. And then the other thing is that it's such a great collaboration that we may see a patient, consider them for a trial, but then we might say, let's get a medical oncologist referral done first. See what they say, whether they think that the patient maybe should have chemotherapy or radiation or whatever. So there's a really, really good back and forth there.
Right.
Yeah.
Just further to that, for everybody's awareness, in Europe, the urologist actually has claimed a very large part of the space for the prescribing of these, if you will, advanced drugs. In the U.S., the pharma companies have deliberate marketing programs where they target the oncologist as opposed to the medical oncologist, and they run all sorts of stats on their success. And in at least the Alberta system, up until you just now told me, Dr. Donnelly is now able to prescribe and one other neurologist. Most of that care was taken care of by the medical oncologists at the Tom Baker Center. So it's just a change, and I found it interesting.
So a really important thing about Calgary participating in clinical trials is that when these drugs are marketed one day, if we don't have any urologists or oncologists who have experience with these drugs, they may be not real comfortable prescribing them. And these could be good things for patients that we want to make sure they have access to. So it's certainly a real benefit for our doctors getting experience with these drugs long before they're marketed. And understanding the side effects and who may or may not benefit from them. Mm-hmm. Any other questions?
See, your presentation was so good, there was no more questions.
Good.